It's a surprise showing of them.
Well, they do say in there a lot of the normal controls had significantly elevated.
Exactly. So high is too high.
You know, on the whole it was higher, but a lot of these patients who were totally normal had significantly elevated specific IgG4. So,
Well, I think it makes you wonder about David's comment. Maybe something else like bad reflux traumatizes the esophagus, and then this becomes an innocent bystander. It also makes me wonder if this could be relevant with inhalants for ENAR. Yeah, you know. Again, those patients also aren't atopic.
Remember when we thought making IgG4 was a good thing with allergy?
It's good until something else
Maybe
happens.
not so good.
Erin also prepared something. I want to make sure she's got time to present it.
Remember all this making IgG4 to allergy stuff, and how that was a good thing. Yeah. Maybe not.
All right, so my topic is on female sex hormone allergy, and there was a paper published in 2013 that demonstrated and supported previous studies that skin test reactivity to female sex hormones in women with primary unexplained recurrent pregnancy loss could be something that we look for in the future. I don't have any disclosures. So basically the American Society of Reproductive Medicine redefined recurrent pregnancy loss, or RPL, as 2 or more documented failed clinical pregnancies. This occurs in about 1% to 2% of fertile women, and about 40% of these cases have no identifiable cause. Hypersensitivity and abnormal immune response related diseases are more common in pregnancy and other situations with excess exposure to female sex hormones, and sex hormone allergy has been associated with adverse reproductive outcomes. The development of an abnormal immune response to sex steroids may develop during a previous miscarriage or previous exposure to contraceptive pills, or as a result of cross-reaction to topically used corticosteroids. And as the skin is the most common organ that manifests signs of hormone allergy, skin testing was then used by several authors to diagnose the presence of hypersensitivity to skin hormones. So that led this group to the hypothesis that primary unexplained recurrent pregnancy loss may be associated with an inappropriate immunologically mediated response to progesterone and or estrogen. And this was a prospective study that they performed in Egypt over the course of a 1-year period. So basically, they took women that were under 35 years of age who had had 2 documented consecutive early pregnancy losses and no previous history of deliveries. Pregnancy was defined as a positive HCG test, a histopathology report showing chorionic villi, or an ultrasound report. Exclusion criteria were a history of certain medical disorders such as diabetes, thyroid disorders, hyperprolactinemia or abnormal prolactin level, history of antiphospholipid antibody syndrome or elevated markers, history of uterine anatomical disorders, and documented maternal-paternal carrier state of chromosomal abnormalities. Women with severe allergies or an inflammatory illness at the time of the study or in the last 4 weeks were also excluded, although not those who had had previous issues like eczema or seasonal allergies, only those that were severe in the recent weeks. So this is just a pictorial depiction of this process, and basically what happened is they ended up with 47 women in the case group and 12 in the control. Their evaluation that they underwent before starting the study was a medical history, including their age, menstrual and obstetric history, history of any medical conditions that I had mentioned, any special habits that may be affecting their fertility, occupational hazards, and family history of any conditions that are consequent. Physical exam included a thyroid exam, a body weight, height, and BMI, and also an abdominal exam, including vaginal exam and pelvic ultrasound. They underwent laboratory studies, including the oral glucose tolerance test, thyroid studies, prolactin levels, and then a full autoimmune evaluation, as well as karyotypes in people who are at higher risk for chromosomal abnormalities. After this, those that were included underwent intradermal skin testing. They used estradiol benzoate, which was dissolved in refined sesame oil, progesterone dissolved in refined sesame oil, and then also a control of the refined sesame oil. These tests were...
You have to use the sesame oil because they're not aqueously soluble.
Yes. So, and then they did the control just to make sure that no one was reacting. Correct. They performed this during the luteal phase, and allergic conditions are reported to be exacerbated during this phase. And then they were followed at 20 minutes, 24 hours, and 1 week for immediate delayed reactions. So at 20 minutes, a positive result was defined as an increase in diameter of greater than 3 millimeters with associated erythema and flare. At 24 hours, they looked for papules or induration that was persistent. And at 1 week, they looked for persistent erythema, edema, or induration. And what they found was about 50% of the study subjects had an immediate positive reaction to both hormones at 20 minutes. This increased for delayed reactions at 24 hours. And 1 week later, there was still evidence of delayed reaction for those who had a positive read at 24 hours. None of the 12 controls had a positive reaction to hormones, and none of the people involved, including the case and the controls, had a reaction to the sesame oil. This is just a table and also a pie chart showing the results here. And as you can see, at 20 minutes, about half had a reaction to the estradiol and half had a reaction to progesterone. And then at 24 hours, it increased to a little bit over half, so 60 or 70%. And that was pretty persistent at 7 days. You didn't see a lot of increase or decrease after the 24-hour period. And if you look at the pie chart below, you can see the majority actually reacted to both versus one of the other hormones. There's been only one other study looking at hormone hypersensitivity and recurrent pregnancy loss I could find. The results also showed a significant association between primary unexplained RPL and skin test reactivity of the female sex hormones, and that was with Exclusion in 2007. And he's actually done quite a few studies looking at allergy or immunologic response at sex hormones. This just happened to be one of them. The only difference that this study cited between theirs and his was that in his study, he did not look at if the women he included had had prior pregnancies or not. I should say viable pregnancies. And this is just a comparison of the two studies. So the light bars are the study that I looked at, and then the dark one was the sex in 2007. And as you can see, there's a little bit of difference in regards to one had more estrogen than progesterone positivity, but the combined hypersensitivity is pretty similar. There's been a couple proposed mechanisms as to what may be occurring in these situations. One thought is that binding of estrogen, progesterone, or the metabolites of blood proteins act as antigens, and you get the Th2 response, which promotes IgE production, and or you get a lymphocytic reaction to the complex, which occurs in the hormones after the hormones bind to these proteins, and that would lead to the delayed hypersensitivity or type 4 reaction. This was done in a study by Roby in 2006, and they actually measured antibodies to these sex hormones. The treatment that they've tried is a desensitization protocol. It's been used to treat progesterone-exacerbated urticaria, premenstrual symptoms, and also has been used recently to achieve viable pregnancies in women with autoimmune progesterone dermatitis. And those are the studies listed below where they've done this. There's actually a recent one in 2013 by Exclusion that also showed that women who were desensitized to progesterone had an increased fertility compared to those who didn't when they had a history of symptoms such as premenstrual or urticaria. This is just an example of the desensitization protocol that they used. And again, this was mostly progesterone. I didn't find a lot using just estrogen or a combination. And so in conclusion, This study is supported by others that there probably is an association between the presence of positive skin test reactivity to estrogen and progesterone and the occurrence of primary unexplained RPL, but further clinical trials in this area, and in particularly to desensitization as a treatment modality, are needed as we move forward. Any questions? Thoughts?
When you reviewed this, did you see any mention of a hormonal anaphylaxis with these women instead of just recurring problem pregnancies?
There were a couple of case reports, but not for this type of study. And it was progesterone that I found. So,
Was the desensitization oral or subcutaneous, or how was that?
I
Progesterone
believe it was oral, but I'm not positive. Let me see.
Oral.
Yeah.
Calendar had something with hormonal anaphylaxis. Follow the people up for him.
Just out of curiosity, did they actually test some of the women that were excluded because of other autoimmune problems? Because you'd almost think that, and I understand why they excluded them, as far as pathophysiology, it'd just be interesting.
Yeah, they did not say that they tested other people who had a potential no reason for RPL.
Gotcha.
So just the ones where they had done all the testing, everything was negative. But that would be an interesting thought as well. There were several articles that mentioned hormones, in particular estrogen and progesterone, as influences on autoimmune diseases in general.
I mean, rarely, frankly, fertility issues often come up, but once a year we see somebody who's reportedly has an allergic reaction to hormones.
Well, and it's interesting because they mentioned that desensitization could potentially be used as well for individuals who have asthma flares during specific menstrual cycle periods, migraines that are associated to the menstrual cycle, and some other disease states. So it, may be something that in the future is used for more than just a fertility issue.
They desensitized them and went through another cycle. Did they resensitize? Because obviously your desensitization is for one part of the cycle.
That I don't have a lot of documentation on. A lot of the studies that looked at it were more for a treatment or for a fertility issue, and so I think after that, there wasn't a lot of long-term after the goal was completed.
I don't know if we still have any outside audience because we lost the audio for a while, but apparently most of the recording was still